Good evening, everyone, and thank you so much, Dr. Vijay. I am not sure I will need the extra 5 minutes, but thank you for so much, and I'll also try to complete well in time. Like all meetings, I believe I'm audible and I'm visually visible.
Yes, Vamshi, yes, you are.
Okay, great, Vijay. So thank you again to the organizers. And as Dr. Vijay said, this is a sponsored session by Novartis. And being a sponsored session, I shall be talking on CERTINIB as one of the frontiers in the first line treatment of ALK positive NSCLC. Now, Dr. Vijay has just completed his sponsored talk on lorlatinib. So it's a nice segue into what I will be speaking on, that is CERTINIB. Now, CERTINIB is something we were very excited about a few years back, and I believe we should still continue to be excited about it. It is still a good drug, and it deserves a place in ALK positive NSCLC. Now, these are my disclaimers. We do know that NSCLC is a heterogeneous set of diseases. Probably the only thing that has changed over the last 10 years is the number of these minor mutations that are coming into picture now. And more, as we treat lung adenocarcinomas, we know that the target really defines our treatment. As much as 60 to 70% of patients are going to develop a lung, have a targetable mutation. And certainly one of the most important remains ALK, which is close to 7% of targetable mutations. Again, when we started out, we thought it's around 2 to 3%, but over the years, especially in India, we are regularly seeing around 7 to 10% of ALK mutations among our patients. Now, coming to the testing, by and large, again, a debate that is almost died a natural death. We would have this discussion of should we do a sequential testing, should we do a more combined testing, should we just test everything? By and large, with the availability of tests, now both NCCN and ESMO are recommending a broad-based molecular testing to look for the targeted therapies. Now, ESMO still sticks a bit to the traditional view of doing EGFR, BRAF, ALK, ROS1, and NTRK. The NCCN, being more broad in general, has suggested doing a broad-based panel of multiple genes. I think in India, most of us are pretty comfortable now doing a 12 gene panel or a 15 gene panel, or in more cases, a 60 to 80 gene panel to look for our molecular testing. And that's kind of the way it has evolved, most importantly because of the pricing. Other than the challenge benefits, of course, you do know that you could detect all the standard of mutations. You could detect it with a higher sensitivity. You could require less tissue to diagnose it. And of course, the turnaround time has become much more acceptable. There is a challenge in NGS. It still is a cost intensive technique. Sometimes you need some technical challenges. Its accessibility is not there for all centers. The turnaround time remains a challenge, but again, we are now comfortable waiting for a couple of weeks for these reports because of the sheer difference it makes in the outcomes. So Novartis does have its own coupon, which helps in testing, which personally I think is a really good thing they have done. So coming on now to the topic of today, that is CERTINIB. Now, the CERTINIB story started with the initial ASCENT trials, the first phase 2 trial, then there was a single arm study, and then came this paper. This is 6 years back, it's only 6 years, but it feels like a lifetime ago in context of lung cancer. This was first line CERTINIB versus chemotherapy in those patients with ALK rearranged NSCLC. It was a randomized phase 3 study by Castro et al. And this was known as the ASCENT-4 study. Pretty basic model. There was not much complicated. ALK positive, locally advanced metastatic non-squamous, no prior treatment given. 1:1 randomization. CERTINIB, look at the dose, it's 750 versus pemetrexate based treatment. You could use cisplatin or carboplatin. And then the PEM arm could continue maintenance. The CERTINIB arm, of course, would continue till the patient had a progression. I really miss such straightforward and simple designs, especially when you come to the multiple hierarchical systems of the latest IO trials. It is nice to sometimes look back at an innocent age when you could simply do a 2-arm study without any complication. Now, what they wanted to look was very simple. As compared to chemotherapy, what was the benefit? And here, Look at the median PFS. It is directly doubled. So with chemotherapy, it's around 1. With CERTINIB, it goes up to 16.6 months. A very nice separation of curves, starts early, continues and builds up. So a median PFS, which is doubled to close to 1.5 years, a hazard ratio of 0.55, a very, very significant p-value. Now, important to also look at other endpoints, the overall response rate of 72.5%, a duration of response of around 24 months, and at least a 24-month initial overall survival of 70%, which was good at the time. But of course, as we'll see later, the OS results have come a little bit of a, I won't say exactly a bad result, but a little bit unsatisfactory. So overall, there was an estimated 45% risk reduction versus chemotherapy, and certainly CERTINIB would be a good alternative, would be a much better alternative than chemotherapy. Now, interestingly, when we talk of ALK positive, we keep talking of this Asian patient subgroup, and we keep talking of the brain metastasis. Two subgroups which are really talked about in all ALK trials. So the Asian patient subgroup analysis, which was done separately for CERTINIB versus chemotherapy, number of patients were not too many, but still in the two arms, CERTINIB versus chemotherapy, again, you started seeing a difference, perhaps a bit later than normal, but a consistent difference which was then maintained. Here, the risk of reduction difference was 34%. Risk of progression or death was 0.66, though it just narrowly missed the confidence interval. Again, we know that the Asian patient subgroup, remember, this is not Indian patients, right? This is Asian patients. We do talk of Asians as being somewhat similar to Indians. I'm not really sure that's the case. I personally feel the Asians, as in the Southeast Asian, the Koreans and the Japanese, are not really similar to Indians. We are more closer to the Western society, but again, we can quibble about this at another point. This is also interesting because we had the ASCEND-8 data. Now, the ASCEND-8 is a trial which I really recommend Novartis for having done. It's not a usual trial that you see from a MNC. Now, what ASCEND-8 did was they actually tried to look at whether we could reduce the dose of CERTINIB. Now, you could use 450 milligram once a day with a low-fat meal, 600 milligram with a low-fat meal, or the conventional 750 milligram per day under a fasted state. So the main advantage of this would be that the patient need not fast. Second advantage, you could give a lesser dose. And certainly in terms of the number of tablets the patient has to take, this is a big advantage. So age more than 18 years, treatment naive, ALK positive status confirmed, performance status less than or equal to 2 with stable brain metastasis. There are 3 arms. CERTINIB continued. The primary endpoint. Now, remember, the primary endpoint was not a clinical endpoint. The primary endpoint was a steady state PK of CERTINIB 450 and 600 and 750. Right? So basically, you were not looking at an outcome wise, but you just wanted to see whether the pharmacokinetic profile was similar. As a secondary endpoint, you did look at the overall response rate and the duration of response with a lot of other bunch of secondary endpoints. Now, when they looked at the Kaplan-Meier plot, looking at the duration of response, PFS, and overall survival. Remember, the PFS and overall are not the primary endpoints, but they were compared later on. Now, interestingly, the best results in all the 3 things, that is the duration of response, the PFS, and the OS in the Asian subgroup population, seem to be better with the low-dose CERTINIB. So 450 milligram had a better over duration of response. It had a better PFS and finally a better overall survival. So in all the 3 parameters, CERTINIB scored over 450 mg, scored over the CERTINIB 750 mg. And since this date, again, I'm just revisiting data which a lot of us know. We are actually kind of comfortable just going directly to a 450 mg, but this is the genesis of that data. Again, when they started looking at the actual numbers, look at the overall response rate, 82.8, 78.9, 76.9. Numbers are small, 29, 19, 26, but still it told us that you could use a lower dose of CERTINIB in a fed state, no need for fasting, and you would end up getting a good result as well. Median PFS, not estimable here, 21.9 here and 8.2 in the 750. Now, this 8.2 is a little disappointing. Remember the first Ascent trial I showed you had a PFS of around 16 months. Now, as compared to that, look at what the previous speaker spoke of, lorlatinib, that was also not estimated. So, you're somewhere going there. The overall survival rate at 3 years, 93% here, 62 and 70.9 in the third group. So again, remember the numbers are small, so I don't think we should really take these as written in stone. However, interesting hypothesis that a smaller dose still did well. And actually by now, I think all of us do take 450 mg as the standard dose. Now, the other important part I told you in the beginning that we keep talking about in ALK is about the brain metastasis. Now, a lot of patients do not have brain metastasis, but 30% of patients could have brain metastasis. This is especially common in ALK rearranged NSCLC, particularly after first generation TKI has been used. So in many patients on crizotinib, around half of them, CNS was actually the primary site of relapse. And therefore, it's good to have a drug which has a high penetrance. Again, when you look at the ASCENT-4 PFS, in patients with brain mets and patients without brain mets, CERTINIB achieved a much better PFS. 6.7 versus 10.7 and 8.3 versus 26.3. Again, look at this number. 26.3 is close to 2 years of CERTINIB for patients without a brain metastasis. Again, you're edging into territory which was traditionally claimed by alectinib and lorlatinib, but it is still a good response of around 2 years. So there is a high response rate, which is durable in patients with brain metastasis. Again, looking at the patient subgroup by Asian population, again had a better outcome, disease control rate of around 83%. And again, best overall intracranial response was significantly better in the CERTINIB arm. Now, the big question, the elephant in the room. Are we going to use CERTINIB as a first line, and what do we compare it with? The important thing is that all the other trials, be it lorlatinib or alectinib, have compared their drugs to crizotinib. Do we have a direct trial of CERTINIB versus crizotinib? We don't. There is a adjusted indirect comparison. Now, again, it's interesting that you have so many indirect comparisons among the drugs and between the drugs, but be as it may, that's the best data we are going to get. This trial was done by a US group, which also had a Novartis representation in it. So, despite that, I think the data still should be something that we can take it. Now, in this cross-trial comparison, they found that CERTINIB had a significantly longer PFS, hazard ratio 0.64. Again, looking at this PFS, 25 months, we are touching the 2 years everywhere when you talk of CERTINIB. So again, in adjusted indirect comparison, it was associated with a significantly prolonged PFS. This is the profile 1014 and this is the ASCENT-4, looking at the absolute numbers. Now, overall survival. Remember, at the beginning, I did tell you this was a bit of a cropper. In crizotinib, you had a hazard ratio of 0.76, p-value non-significant, crossing the unity 1.053 with a pretty good numbers, 172 and 171. Remember, this is against chemotherapy. And the reason, obviously, is because of the crossovers. When they looked at the CERTINIB data, again, though the overall survival was not estimable here versus 26 months in the chemotherapy arm, which is actually lower than, the crizotinib arm, the hazard ratio still 0.73 and crossing the unity, just missing the significance. So again, CERTINIB versus chemotherapy did not really show an overall survival advantage, mainly because of the crossovers. So the PFS is what we got there. Always you are concerned of safety. ASCENT-4 showed there was both in the QOL as well as in the adverse events. It significantly improved the quality of life, significantly prolonged time to deterioration. Now, when you look at the ALK inhibitors, you do have CERTINIB, you have crizotinib, you have lorlatinib, you have brigantinib, and you have the alectinib. We could probably leave out brigantinib as we still don't have it in India, but alectinib, CERTINIB, crizotinib, and lorlatinib are all available. The approvals have come one after the other. So we have all 4 in India now. Looking at the NCCN guidelines, the preferred drugs remains alectinib, brigatinib, or lorlatinib, all category 1. Interestingly, though they have put CERTINIB in the other recommended, it still remains a category 1, as is crizotinib. So 4 drugs all could be considered as category 1. What is interesting for me is if you kind of take the CERTINIB PFS around 24 to 25 months, follow it up with alectinib, and then follow it up with lorlatinib, you are tending to get a quite long PFOS versus lorlatinib alone, followed by, well, only chemotherapy mostly, or alectinib followed by lorlatinib. So all these 3 are kind of comparable. The question really is, would it be easier to give CERTINIB first, then alectinib, then lorla, or simply use lorla upfront? I don't think we are ever going to get a first-line trial in this. Nor are we going to get a trial of alectinib versus CERTINIB. I think both lorla and alectinib were tested against crizo, and that itself is quite a big achievement. Beyond that, we just have to rely on these kind of data, which say that, yes, you could still sequence your trials. Again, this is what we know today. Probably after a couple of years, whether this holds true or whether we get new overall survival data is still open to question. Personally, would I still be considering CERTINIB in today's age? Yes, because number 1, it is definitely cheaper. Number 2, it's a proven drug which works in several situations. If a patient doesn't have brain metastasis, definitely CERTINIB would still be as part of my thought process. With brain mets, I think you cannot really deny the impact alectinib has had or lorlatinib has had for that matter. So in the patients, at least without brain metastasis, CERTINIB remains part of our discussion and definitely remains part of the first line. Of course, we do need to look at the efficacy because several patients may not survive to receive the second line. So that could be one reason to use a stronger medicine upfront. Dr. Vijay did make that point that you should use your strongest medicine first. It's a question we need to discuss with the patients. No brain mets, definitely this is where I would still be using a drug like CERTINIB. When you have symptomatic disease, by and large, all the drugs give us a good rapid response. And second line drugs being available at progression gives us a feeling of happiness that, you don't have to jump and give chemo. You can have some of the other option as well. So to conclude, SN4 trial showed that CERTINIB has improved PFS and numerically better OS, though the data is still not mature. PFS benefit in both brain mets and non-brain met patients. GI events pretty much manageable, especially with the lower dose of 450 mg. And as I think by now, it's kind of moot to comment about it, but safety and efficacy are pretty much well established in the Indian patient. So thank you, and back to the organizers.